Okay, we're going to talk about joint replacements and amputations and other musculoskeletal traumas that you might not have had in previous semesters. So first thing we're going to talk about is total joint replacements, and the first one of those we're going to talk about is total hip. So this is a picture of the normal hip joint. You have a nice intact acetabulum. You've got a nice amount of cartilage at the joint. You've got nice strong bones, and everything is feeling just marvelous. And then you've got the patient with osteoarthritis, where you've got a lot of degenerative joint disease, a lot of deterioration of the bone, and deterioration of the cartilage. So patients at some point have a significant amount of bone on bone where there is no cushioning. So what are some of the reasons why a patient would need to have a total hip replacement? What are some of the indications for that? Fractures. Some types of fractures will require a total hip replacement. Chronic pain. So significant pain that doesn't respond to conservative treatment. And usually that's NSAIDs, cortisone injections, those sorts of things. What other reasons? Immobility. But why would immobility create a need to get a total hip replacement? Yeah, inability to perform normal tasks. So, the inability to walk normal distances, so pain. So the inability to work or sleep or just move normally because of the pain. Other times that patients might need a hip replacement is if they've had a hip replacement in the past and the hardware loosens up and they have to have a revision or a complete replacement of the total hip replacement. This is why a lot of physicians will tell patients, if you can take it for a while longer, let's try to delay this because we don't want to have to do it again when you're 75 or 80. Because usually the prostheses will last 10 or 15, sometimes 20 years, depending on the age of the patient, their bone mass, their weight, and at some point that prosthesis can loosen or dislodge. Tumors in the hip joint can sometimes necessitate the total hip replacement. What would be reasons why someone could not have a total hip replacement, even if they needed one? Muscle atrophy. Well, who else?
Cardiac problem.
Yeah, cardiac or respiratory or any other severe comorbidities that would make it difficult for them to survive this type of invasive surgery. Yes, Kate? Obesity. That patient who, because you're going to be bearing weight on that hip almost immediately after surgery, and if that patient is too obese, then they might dislodge or remove their prosthesis or break their bone. What are some other reasons? Advanced age, but a lot of times if they don't have other comorbidities and their bones are in good shape, it's amazing how old patients are that they will actually do hip replacements on now versus 25, 30 years ago when I first got into nursing, where anybody over the age of 80, it was pretty much a contraindication. Now I've seen them 80s and sometimes early 90s. Yes?
If it's too severe osteoporosis?
Yeah, if they have severe osteoporosis, that would be a contraindication, because when they do this, and I show you the picture of what they do, and I'll actually show that to you now. The first part of the procedure is they cut off the head of the femur, and then they kind of ream out the acetabulum to make it nice and smooth. And then, whoops, we missed this, we went too far. Then they put in a new socket, and then they put in a new head of the femur with a shaft that literally gets hammered down into the shaft of the femur. So that patient with severe osteoporosis isn't going to be able to tolerate that. The bone's just going to crumble. And if it doesn't crumble during the surgery, it's going to crumble the minute they put some weight on it. So any kind of severe osteoporosis. The other contraindications might be mental or psychiatric illnesses that would prohibit the patient from being able to comply with the post-op plan of care and all the restrictions and other types of issues. So that is your procedure, and this is what it's going to look like after they have the hip replacement done. So that nasty, painful joint is now a combination of steel, plastic, titanium, all kinds of fun stuff. Now your patient has come back from the operating room. They've had a total hip replacement. What do you expect to see when they come back from PACU? What kinds of things are you going to see? A drain. So they're going to have a large dressing with a drain because orthopedic surgery is very bloody, and there's usually a lot of bleeding in the operative area. So they drain the bloody drainage out of there. Some facilities will use a red blood cell collecting device. At Johnson, we use the Orthopat brand. And what it does is it takes that bloody drainage out of the joint, separates the red blood cells from the debris, and puts them in a little IV bag. And then when the drainage gets to be a certain amount, usually 50 to 100 mLs, the doctor, depending on the doctor's orders, we retransfuse that into the patient because it's been cleaned out and all the debris and junk and everything, so it's nice red blood cells that the patient has. Other times patients will donate their blood a few weeks preoperatively, and then they will have an autologous blood transfusion. Because any orthopedic surgery, very bloody, patients tend to lose a lot of blood. If the hip replacement was because of a fracture, they will have lost probably a lot of blood because they tend to bleed a lot with hip fractures. What else? A wedge pillow, an abduction pillow. What does that do? What's the purpose of that? Keeps their legs in abduction, so separated, so they don't cross their legs. What's going to happen if they cross their legs post-op? They're going to pop the prosthesis. Another way that we can prevent that patient from popping the prosthesis out is making sure that they don't flex the hip greater than 90 degrees. So when you're getting them out of bed, make sure that they don't sit down in a very low chair, which would cause their hip joint to flex beyond that 90 degrees. So they're going to be in a high straight back chair, they should be. They should have an elevated toilet seat so they don't have to get down and again flex that hip greater than 90 degrees. They shouldn't be bending over and picking things up off the floor immediately. So they should have one of those grabber devices to go home so they can pick things up off the floor. What other things would you see post-op? How about pain control? Most of them will have a PCA pump, and usually an epidural PCA pump. Let me see. Are they going to be at risk for DVT? Yep. So what are we going to be giving them? Compression stockings or the pneumatic devices, and what else? Lovenox or sub-Q heparin. Prophylactic antibiotics. Patients can get a lot of, at a very high risk for infection, so oftentimes they'll get a very heavy dose of antibiotics pre-op, and then at least a 24-hour, 3 to 4 doses of an antibiotic post-op to make sure they don't develop any infections. So they should avoid crossing their legs. They should avoid undue flexion of the hip, and that's where we have that abduction pillow and everything else. Yes? Uh-huh. And that's probably unique to a particular physician or group of physicians, not necessarily something that's routine. Because I've never encountered that with the doctors at Johnson or at other hospitals that I've worked at. Yes? Right, yeah, and that is the, but in terms of the huge doses of steroids was something I had not really heard about. Okay, they were looking at the trends, and like we talked about with critical care, glucose control is very important in critical care, and they're finding very important with a lot of other post-op and other types of situations to promote healing. So that's the total hip. And now we're going to talk about the total knee replacement. So this is what the knee is supposed to look like. This is where I have no cartilage in the medial femoral condyle. This is where I do not have a meniscus. But we're listening, but I digress. So this is what the normal knee is supposed to look like. And then what will happen is osteoarthritis, degeneration of the cartilage, degeneration of the bone, weakening of the padding, and so eventually people will get bone on bone. So the indications are very similar to the reasons why people need a total hip replacement. So severely limiting pain that's unrelieved, that limits their mobility, their ability to work, their ability to sleep. So any pain that's not responding to conservative treatment like cortisone injections and that sort of thing. Patients who have had a total knee replacement in the past and the prosthesis has loosened, the hardware has loosened up. And some knee fractures can necessitate a total knee replacement. Now before they do that, one of the newer things that they've been doing to prolong and to kind of delay the eventual need for the total knee replacement are what they call viscosupplementation. Those are the gel injections my doctor's been talking to me about, which I just called him and said, set them up, because I'm having a lot of pain. And what it is, it's a naturally occurring lubricant that's in the knee joint that they've either synthesized or biologics that they use, and they will inject them directly into the knee joint, and it provides cushioning, takes the place of the deteriorating cartilage that the patient has. For many patients, this is all that they need, a couple of injections, 2-3 injections once a year or even twice a year to not need a knee replacement at all. Yes?
What's the name of it again?
It's viscosupplementation. It's just gel injections. There's a couple of different brands. The most common one that I've heard being used around here is Synvist, S-Y-N-V-I-S-T. So that's part of that whole conservative treatment for that patient before they do the knee replacement. And this is what they do. They shave off the head of the tibia, get rid of all of the loose cartilage and any other damaged issues. They shave off the end of the femoral condyles, and they put that new prosthesis in place. And part of that new prosthesis is a new tibial plateau with a shaft, again, that goes down the shaft of the tibia. So a patient with severe osteoporosis, again, it would be a contraindication because the bone would not be able to tolerate that procedure. And this is what they refer to as minimally invasive. If somebody could dim the lights. This is minimally invasive. The Stryker navigation system puts little GPS trackers on the ends of the bones, and then they align the knee using the computer. So because it's a much more precise alignment of the femur and the tibial plateau, they don't need to use that part of the prosthesis with the shaft that goes down the shaft of the tibia. They're able to line things up and straighten them out. It's a much quicker recovery, and it is a much shorter hospitalization time. And the doctor that there was a doctor at Bay State, I think he was a urologist, had both of his knees done at the same time using this procedure and was playing golf 3 months later. So that is a possibility. What are you going to see in terms of aftercare for your patient that has a total knee replacement? A continuous passive motion machine, CPM. Many physicians will do that. Some won't, but many will. And what that does is it continually flexes and extends that knee joint so the prosthesis doesn't freeze up. They're going to have a bulky dressing with a drain, oftentimes the orthopad or other type of red blood cell collection type of drain. And then usually after the first 24 hours with both the hip and the knee, they convert that orthopat to a regular hemovac drain. And then that's usually out another 24 hours later unless the patient has a lot of bloody drainage from the operative site. PCA pumps for pain control, usually epidural. Autologous blood transfusions, if it's a planned total knee replacement, oftentimes patients will donate their blood prior. Yes?
Acute a lot of them had a nerve block.
Oh, great. A nerve block.
They all did.
They all did. So none of them had PCAs post-op? Awesome. Awesome. Excellent. Did they have the CPMs? No? Yeah, a lot will depend on the physician and what they like to use. The cryo cuff, yeah, the ice pack, that's a continuous ice pack. They're usually going to also have the prophylactic antibiotics, anticoagulation to prevent DVTs, early ambulation, regardless of which type of knee replacement that you get. They're going to have you up very quickly afterwards, walking and moving. Because again, the key is to not let that prosthesis freeze up. So any questions about joint replacements? Okay, amputations. There are two types of, yes? Similar to the ones that, yeah, only not as restrictive as the hip, because you don't have a lot of the post-op restrictions in terms of flexion and abduction that you do with the hip. You know, as long as the patient was alert and oriented enough to be able to walk and follow directions, you know, on how to, you know, they're not going to have the restrictions post-op that the total hip would have. For types of amputations, they can be either traumatic or surgical. A lot of the patients that you're going to see routinely have had surgical amputations, oftentimes because of diabetic ulcers or other types of peripheral vascular diseases. AKA is above the knee, also known as, yeah. BKA, below the knee. Patients oftentimes with the diabetic ulcers or peripheral vascular disease, they start off with maybe a transmetatarsal across the instep of the foot, and then that doesn't heal well, and then they end up getting usually a below the knee or an above the knee. Patients with severe PVD may also have a femoral popliteal bypass prior to the amputation, because they want to restore adequate circulation to that leg so that the amp site will heal. What are some of the possible complications of the patient that's had an amputation? Hemorrhaging, infection, contractures. Patients who have had, say, a below-the-knee amputation, if they're sitting up in the wheelchair, the stump will usually be hanging over the edge of the seat. So that knee joint can become contracted, so you need to make sure that their leg is straight. Patients who've had an above-the-knee amputation, if they're sitting up in the wheelchair for long periods of time, can get a hip flexion contracture. So you need to be doing range of motion with these patients and positioning them so that they don't develop these contractures. Patients with an above-the-knee amputation, if they can tolerate being on their stomach and lying prone several times a day, usually 2 or 3 times a day, to stretch out that joint, then they won't get the contractures. So range of motion exercises, positioning, rigid or elastic dressings that are going to help to mold that stump so that it can be fit into a prosthesis. What is phantom limb pain? Right, where the patient will feel pain, or maybe the limb will feel distorted or out of position. And many patients will have this complication. Others will never have this problem. So they really don't know what causes it. Usually it's because of the nerve endings are still trying to transmit information to parts of the body that don't exist any longer. So patients will have different types of treatment for phantom limb pain. Primarily pain control, because this is legitimate pain that they are experiencing, even though the leg that they're feeling the pain in doesn't exist anymore. So you're going to be giving them medications for pain. Calcitonin, IV calcitonin can sometimes help. Beta blockers can help. Tegretol or Neurontin can help. And a lot of times what patients have to do is to figure out under what circumstances they get these episodes of phantom limb pain and try to prevent them from occurring. Now the rest of the slides in this particular unit are not going to be on exam number 4. So common musculoskeletal injuries, look that up in Pellico, talks about contusions, sprains, and strains, what the differences are, and what our interventions are and our assessments. So know those for the NCLEX. The same thing with everything that is on this particular slide here. Not for exam 4, study it for the exit exam or the NCLEX. And then the last thing I'm going to show you are a couple of videos. One is a meniscus repair and the other is a rotator cuff repair. Just a minute here, let me just stop this.